Okay, so deep orbit, small eye, narrow palpebral fissure, leading to all the different difficulties in the various steps of the LASIK, which I will be talking about later. And the second most important thing is the inadequate suction. Why it happens? Because of there is a suction loss because of the blocking of this microkeratom assembly due to the debris, draps, speculum, there's a chemotic conjunctiva. And all this leads to the different type of flap complication like irregular flap, incomplete flap, free flap, buttonhole. Now just quickly see this video. I'll be showing mostly the videos. Here I'm trying to make this is early LASIK days when I was learning. I'm trying to make the flap with the M2 Moria M2 microkeratom with the 130 micron. I have marked the chorea. Now just see, I'm applying the suction ring over here. Just keep in close eye now, just see over. It looks absolutely fine. Just see the downward movement over here. And you can very well see that there is a suction loss you can see, and this is the only incomplete flap over here. So the flap is not complete, just see this. This is an incomplete flap. So here in this scenario, you cannot go ahead and proceed with the ablation. You have to abort the procedure, but you have to make sure that all the flap margins are properly opposed to prevent any epithelial ingrowth. So what do we do next? So we have to basically wait for at least 3 months. Nowadays, I wait for around 8 weeks for the eye and reflection to stabilize, and we either do the surface ablation or we recut. Another quick video. This is again the older days. Now with this Moria and SBKs, the complications are absolutely almost very negligible. Just see here, this motor is stuck over here. Ideally, it has to still pass this passage, but it is stuck over here. So here I know that my flap is still not complete. It's an incomplete flap. But fortunately, when we lifted the flap, you can see that it is beyond the pupillary margin. So here I got escaped. I reduced optical zone from 6.5 to 6 millimeter, and I was able to go through. So the next thing is the management of this incomplete flap. So if you have incomplete flap and you have sufficient area or room for the ablation, you can reduce the optical zone from 6.5 to the 6.25, 6 millimeter, but you should not go beyond the 6 millimeter zone. And if you any condition like this is affecting the pupillary area, then you have to abort the procedure. This is another thing which we tried. Here you can see this is the incomplete flap already. You can see this over here. Here we in my practice we only do the 90 micron flaps. That is the reason something goes wrong. Then I always have the space to do the deeper cut. So the thing here is to make a flap which is slightly smaller and the deeper. So initial flap was 100 micron. Here I'm making a flap with 130 micron. You just see I'm double confirming the vacuum. So most important thing here is to identify whether the vacuum is properly built up or no. First, you can see on the microkeratom machine, it should be within the range of 120 to 160 millimeter of mercury. Then you lift it up slightly to make sure it doesn't come out easily. And third thing, you ask the patient whether the patient stops seeing the lights. Here you can see how easily I am able to make this new flap. There is no intersection between the newer tissues and the older tissues, and the rest of the procedure is same like a normal LASIK one. This is how the post-op 2 edges are seen. This is the older flap margin. This is the newer flap margin. But what is the drawback of this microkeratom recut? Many of the times, the older flap tissues and the newer flap tissues can intersect with each other and result in the silvers of the tissue. Whatever happens, do not try to remove them. Otherwise, patient will end up having the lot of visual difficulties. It is not that the vacuum loss and everything happens only with the microkeratom. Here you can see I'm trying to make a flap. Already there is a vacuum loss over here. I'm trying to make a femtosecond flap. As you saw in the video, it was only half, but that is the beauty of the femtosecond lasers. Here you can resume with the same parameters, with the same settings, and in the same plane. You just have to wait for around 5 to 6 minutes for the bubbles to appear. So I'm again docking it again, and you'll be amazed to see how easily I'm able to lift this flap without any trouble. You just don't feel like something has gone wrong. So that is the advantage of the femtosecond laser. Next is the free flap. Why does it happen, sir? What are the anatomical factors? Most common anatomical factors are the large cornea, flat cornea, high mixed astigmatism. Here you can see my ring size is +2. Here I'm trying to make the SBK 1 use plus 90 micron flap. Here, by mistake, I am selecting the +2 ring. In SBK, suppose 0 will have the maximum range, +1 will have a shortened one, and +2 will have a more shortened one. So here, ideally, I should have used the ring of the +1. Just see now what happens. You can see that this is the free flap, and the flap is always here. So just try to see first into this blade keratom assembly where your flap is lying. Just see over here. This is where this is a 360-degree flap. So now how will you treat this case? Whether you will go ahead with the ablation, whether you will not go ahead with the ablation. So what we do, we can easily go ahead with the ablation. This is another free flap which has already happened. Then I started recording. So I'm just putting it aside, making sure the epithelial margin is this side and stromal margin is this side. Even if you don't know which side is the epithelial one and which side is the stromal one, you just scratch it out with the cannula, and the rough side would always be the stromal side, and the epithelial will slightly peel off. So you can just put it aside, do the laser ablation, and align it. If you have marked the cornea very well, nowadays we don't mark the cornea. So as I told you, first is to identify which side is the epithelial, which side is the stromal one. So once you have done that, you just put the flap back, and there will be some areas of some notches or irregularities which you can align with the flap margins and get away. It is not that this free flap happens only with the microkeratome. Again, the femtosecond laser, this is one of the unique case which I encounter. I've already made a flap. I'm trying to lift the flap. This is my earlier intralace days when we had it for the demo. And just see here, I have made a superior hinge and I'm trying to separate it. You'll be amazed to see the patient is absolutely non-cooperative. And my mistake was that I was also anxious. I was not talking to the patient. And suddenly there is a jerky movement while I'm trying to dissect. And oops, there is no longer hinge available right now here. You can see here. So now what to do? But suddenly the idea struck my mind. Here I have still not yet fully dissected the flap. So I converted my superior hinge into the inferior hinge somehow and completed the ablation. So you have to do it very carefully. You have to make sure. So just like this, I converted from superior to inferior. You can get away. So as I told you, for the free flap, I already discussed large flat corneas and how to prevent. You have to still nowadays, I was not doing it, but after a couple of cases recently, I started again marking those flat corneas like this with these markers. And dreaded complication. Can I just have 1 or 2 minutes more? Okay, so most dreaded complication I'm worried about is the buttonhole. Most commonly it happens because of the reuse of the blades and the poor quality of the blades, and many other times we are overusing the anesthetic eye drops. So nowadays what I'm doing, I'm just only putting the anesthetic eye drops when a patient is on the OT and the same eye which I'm going to operate. If I'm going to operate right eye first, then the right eye, and the left and the left. And again, the steeper corneas, irregular astigmatism plays a huge role. The better they are prevented. So identify the risk factor like I told you, avoid the aggressive use of the anesthetic eye drops, change the blade after every cut, do not reuse them. And that is the advantage I think we have with the femtosecond lasers now, because there is no way you can reuse those specs because your license gets counted. So how does the management? Depends on the location, size, and the type. It's a partial thickness like this, away from the pupillary margin. You can safely go ahead with the ablation. Just put the BCL and wait for the epithelium to heal. But if it is central and partial or full thickness, one cannot go ahead. One has to abort the procedure. Make sure the margins are properly opposed. Push the BCL for 2 to 3 days. Make sure epithelium is properly healed. There is no epithelial ingrowth. It then depends on the further management. Depends whether it is associated with the epithelial ingrowth or no. If no, you can easily go ahead with the PTK with the mitomycin C or PRK with mitomycin C. If the epithelial ingrowth is there, first you have to take care of the epithelial ingrowth by doing the PTK. Then you have to combine it with the PRK with the mitomycin. Again, it is not that the microkeratome causes this. Now this is the unique case of the buttonhole, which we call it the vertical gas breakthrough in case of the femtoLASIK. Just see here, I'm trying to, you can just see that the dissection is quite going very well. This laser formation, the bubbles are quite good. Just keep it close eye over here. While it is about to get over, suddenly I don't know what went wrong, and I have this area of the vertical gas breakthrough. Nowadays, with the advanced laser, the incidence of these are quite low, but still, it can happen to anybody. So I knew that in that area, dissection would be very hard. I was not able to dissect with the normal spatula, so I had to use, in this case, the keratome. Just see, I'm trying to separate it with the, crescent blade. And I was able to do it. I got lucky. So I think these are some of the cases. And the idea is to show you that the complications are going to happen. Whatever complications are there written in the books, all of them I have encountered. I think Parimal Uncle has encountered. We all have encountered. But thing is, if you manage well, you can come out with the flying colors. That is a take-home message. Thank you very much.